So it's my pleasure to invite the speaker again, Dr. Mohammed Al-Umair, and Dr. Bushair will open the floor for a question. Yes, Doctor.
Many thanks for this intelligent session regarding abstract. I have a question to Dr. Umair. Do you have any data about indices of activity in those patients using complementary medicine and those not use, like DES-28 or something like that?
Yeah, unfortunately, the principal investigator of this study, because of the multi-center nature of the study, many of the centers do not do DAS-28 or other outcome measures, so we did not really have any of these outcome measures, unfortunately.
Do you recommend to prescribe complementary medicine for our patients to avoid their search on other sites؟ يعني احنا بنشوف حالات كتير معظم العيانين بيلجأوا للكومبلمنتري ميديسين حتى الهايلي educated. Do you recommend ان احنا نوصف ولو حاجات زي الاوميجا 3 or something like that to avoid the patient to search on other sites?
So some of what is considered complementary medicine is actually prescribed by us, like vitamin D or multivitamins. So this is all considered complementary medicine by definition. Now, as clinicians, we always, or health advocates, we always advise patients to use a medication that has an evidence-based proof that this medication will make a difference or improve the patient's status. Saying that, patients, it's always better to build a good rapport between the physician and the patient and to be engaged properly. So if the patient is going to use a complementary medicine, he's going to ask you first. I think the most important advice is that you tell your patients, whatever you want to use, just let me know about it.
Yes. My question to Dr. Abdul Rahman, why no يعني الانتي-histone antibodies on the immunological profile, I don't find any data regarding that.
About which antibody?
Anti-histone.
And it was not done in that center initially. We found it only in 2 or 3 patients, and it was negative.
Yes, okay, thank you.
السلام عليكم. Dr. Abdul Rahman, يعطيك العافية. What I gather from your presentation, maybe the site of lesion might be a suggestive of this side effect or complication. But did you look in the histopathology? Would it be useful to differentiate between the drug-induced versus the idiopathic?
Yes. Around half of the patient with BBI-induced SLE underwent skin biopsy, and there is no pathological feature different than primary SLE. So taking a biopsy will give a result that this is a connective tissue disease-related rash, but it will not differentiate between if it's primary or drug-induced.
I have another question, Dr. Mohammed, regarding the complementary or alternative medicine or agent. The main concern, we are talking about non-complementary agent, not unknown. Unknown, nobody can argue with that. It's not safe enough. But even the non-complementary or alternative, sometimes it's difficult even to say it's okay, because these medications, we don't know if it will interfere with the anti-rheumatic drugs in terms of either increase the bioavailability or decrease. So we don't know the interaction between this agent and the anti-rheumatic drugs. If you don't mind to comment on that.
Yes, so I agree. This is an important point. Now, there are many things that are well known to us. For example, honey do not interact, black seed do not interact. Now, if a patient comes to me with a bottle of ginkgo biloba or some kind of aphrodisiac, calm or whatever, what I do, I consult with my pharmacist, and the pharmacist runs the drug slash food interaction or drug-drug interaction. So whenever you are not sure, I think Professor Salman has a very important point. Whenever you are not sure, okay, you have to run a drug-drug interaction or drug-food interaction to make sure that you're not missing a point. But again, I would like to emphasize that many people use some kind of complementary medicine where you don't know what is the content of this. And let me tell you a funny story. I thought that Attarin were criminals in our country and they should be locked till I saw the first Attar shop near a friend's house. So it's embedded in our culture, it's embedded in our religion, and you have to be very open-minded with your patients so that they not do it behind your back.
I have a question for my colleague, Dr. Abdurrahman Al-Rashid. Did you notice any such case, PPI and use SCLE in Saudi Arabia?
Personally, no, I did not encounter any BBI-induced SLE locally.
And just I would like to know, regarding the, do we have any specific drug from PPI that can cause this condition, or it's in general?
No, all 4 BBIs were associated with this phenomena. Maybe omeprazole is the commonest one, but all of them were reported. Locally, I think most of these patients maybe will be referred to dermatology, and maybe because of this, we didn't see it in dermatology clinic.
Thank you, doctors, for your great presentations. My question is for Dr. Abdurrahman. For the BBI-induced reaction or condition, was it linked to the duration of therapy or the dosage form of the medication, IV, for example, versus the oral?
Actually, the report includes both dosage of BBI, the small or the high dose. So there's no difference. And in regard to the timing, we have a few patients within a few days of starting BBI, they reported this skin rash. And one of our patients, he developed or she developed this rash after 12 years on BBI without any change in the dose or change in the brand. So you cannot predict or saying timing is is related to develop of this SLE.
Okay, thank you, doctor. The other question for Dr. Mohammed. So how can we control between the patient preference and, as you mentioned, the cultural belief between the use of complementary medicine or in general the Eastern way of treating some conditions and our usual practice of using medications?
Well, as I told you, what is your level, Doctora? You are?
Clinical pharmacist.
A pharmacist. We mature as we gain years of experience, and many of our beliefs or thoughts or strategies to reach to some target change over time. And I used to be very closed-minded in use of complementary medicine with patients. So now with the study that we have done, and we have seen that many patients are actually not telling you because they are afraid that the physician would not understand or would reject this. The most important thing is being very open, having an open discussion with the patient, okay? And as I told you, as a clinician, you should not advise for any treatment that you don't see of benefit, but you should not prevent any medication or any use if there is no clear evidence or at least it's common sense that it might harm a patient. واضحة يا دكتورة؟ يعني if a patient tells me that well I want to use ginkgo biloba and the patient is on methotrexate and etanercept and I do a drug-drug interaction, I don't see anything, I will tell the patient, just use it. The thing that you always give the patient the option. Once you give the patient the option, he feels that he's free to do whatever he wants. He will go back and listen to you. طيب. And sometimes you tell the patient, you know what, try it for 3 months. If you see any benefit, well and good. My patient report outcome are going to improve. The pain, patient global assessment are going to improve without me changing anything. If the patient does not improve, nobody wants to pay any money without any seen benefit. So many of these products are actually expensive. And I always go with my senior colleagues on a very long, endless argument on glucosamine supplement in patients with osteoarthritis. This is again one of the very known examples in adult rheumatology, oral glucosamine. For me as a clinician, I see it has no evidence, it has no use, but some patients, they tell you, I improve on it.
Yeah. Okay, thank you, doctors.
I have a question to you, Dr. Mohammed. I came across some of the evidence supporting the use of omega-3 in rheumatoid arthritis. Because it may exhibit some anti-inflammatory effect. And we used to have this question almost on a daily basis in our practice. I don't know what is your advice for those patients, considering the point of Professor Mayouf that we are lacking the details about the interaction with the DMARDs.
Again, thank you. This is again an excellent point, is that some medications, either biochemical medication or complementary medicine, mechanistically makes sense. They might improve inflammation and improve patient status. But again, you are always guided by a solid evidence through either a randomized controlled trial or a pilot study that tells you that using this medication has improved these patients. So for example, if you saw the study that Prof. Suzanne Attar has presented yesterday about the deep nerve stimulation, this was a very exciting abstract presented in ACR 2020. And again, we don't understand exactly how this works, but this will be a beautiful option for patients who are refractory to many medications. So this was a well-conducted study. I think this was done by colleagues from Harvard who have done this study. So you have to have a solid evidence to give a patient an advice, or you open the way for the patient to do his trial and error of the complementary medicine. يعني some things make sense, but there is no real evidence. يعني يقول لك والله إنه some of them are actually laboratory findings, improvement. So we have one colleague who's working on some type of snake venom, and they found that the snake venom reduces many cytokines and reduces many activated T cells. But again, you cannot prescribe snake venom to patients, at least for now.
Thank you, Dr. Mohammed. Thank you, Dr. Abdurrahman. Now we'll close the session. Thanks for all.
Dr. Mohammed Sultan, Dr. Mansour. Thank you, respected chairpersons and the authors and investigators who participated in the abstract session. I guess because of the healthy and interactive discussion following this session, we decided to keep it going on at the cost or expense of the break. So what we will do is that we will go on a 10-minute break. It's 10:30 now. We will be returning back to this hall at 10:40, and we will start the Novartis Satellite Symposium. Thank you.